PCBH model. Look at this picture. I like to show this to our first year family medicine residents during orientation. They're fresh out of medical school. Some of them are really excited to be practicing. Some of them are, most are petrified because they're not responsible for some really complex patients that they have to work with. And so this is usually what happens. Zeke can vouch for this during at least the first 6 months of their first year, is they come out of the room and they are very scared, nervous, or they say, I don't know what to do, please help me. Or my patient's crying, that's a big one. It's like, well, did you just tell them they had cancer? Then yeah, they should be crying. That's okay. But way too much information happens more than you think with PCPs. So this is where you all come in to help them. So this term is essentially a nice umbrella term for what behaviorists do, and primary care providers too, not just us, but them too. What happens in primary care? So essentially, for the longest time, we'd focus just on mental health and substance use issues, saying that, well, we'll just treat those, and then all the other stuff we'll let the PCPs do. Has anyone ever worked with a patient who has type 2 diabetes? Okay. Are there behavioral changes that they have to make for that? Okay, what changes do they have to make for that? Diet? Exercise? Sleeping habits? Okay. Self-care, absolutely. That's, yeah, absolutely. Absolutely. They have to take medication. They have to check their blood sugar. And if you've never done that before, and then you get the diagnosis that you have type 2 diabetes, go to all these appointments, figure it out on your own, good luck, which is what happens to a lot of patients. So that's why I say behavioral health, that fits under this too, working with patients with chronic health conditions. Every chronic health condition, there's a behavioral component to it, every single one. Even if it's taking a medication, that's a choice that a patient has to make every day for some patients. So you can help with a lot of things. So don't sell yourself short thinking that, well, I'm just here to treat depression, anxiety, substance use, that's it, family conflict, that's it. You guys can do so much more than just that. That's important, but don't forget that you can help with the stress-linked conditions too. So that's everything else that shows up in primary care. And then primary care behavioral health, there's a lot of definitions for this. I think this one sums it up very nicely. Essentially, the patient feels they've come to the right place. They feel that I can come to this one place and be treated by my team. Some of our patients say, I have a team here that they feel really comfortable with, that they can get a lot of things addressed. But they don't have to go to 16 clinics to get these things addressed. They can come to one place. So that's our hope of what we're trying to accomplish. So take a look at that. There's a lot on the screen. But when I have new behavioral health consultants say, well, what am I treating in primary care? What am I doing? I say, well, this is a start. This is a start of what you may be helping with. And so through today, and then through the course that you will take next semester, we're going to train you how to be solid generalist for primary care. Solid generalist. It doesn't mean that you can't have your specialty if you really like kids, or if you really like older adults, if you really like this one condition, that's okay. Keep that, but you still need to know how to treat all these other things that show up in primary care. So of course at the top, that's what people think of the most. Does this have a pointer? Oh, no. Just kidding. Uh-oh. Okay, it's back. Wait a minute. Yeah. Okay. Ooh, wrong button. So of course people look at depression, anxiety first, but don't forget about diabetes and distress and lack of a social network or health behavior change, quitting smoking, things like that. So you may say, oh my gosh, I wouldn't know what to do if a patient with insomnia came in and I'm supposed to do CBTI. I don't know how to do that. We'll teach you how to do those things. So our hope is that you'll feel confident and comfortable dealing with a lot of different things in primary care. Uh-oh. Okay, all right. Dealing with a lot of things in primary care. You don't have to be an expert on irritable bowel syndrome, okay? That's not what I'm asking you to do.
Thank you.
You're welcome. You don't have to be an expert on how cancer affects the body. But you need to know a little bit about a lot of things. Primary care providers, they're the generalist of medicine. They have to know a little bit about a lot of things. The same is expected from a behavioral health consultant. If PCPs are expected to see anything that walks through the clinic, so are you all. Zeke, in a typical day, what types of conditions would you see just in the morning? Is it all the same, or what kind of things would you see pop up just say in a half day? Putting you on the spot.
No, absolutely. I think, yeah, you really do see a large variety, and also just the comorbidity as well, right? So you see some patients who, yes, they have anxiety, but then they're also having headaches because of that anxiety, right? Or some like GI issues that are associated to that. So how many specifically? I mean,
is it all depression, or does it bounce back and forth?
I think that I would say a rough estimate of like, it's pretty close to 50-50. I would think. What do you say? I don't know. Like in terms of like medical conditions and more like primary mental health conditions.
I'd say I'd agree with that for sure. You could go from a consult for depression to chronic pain to substance misuse to caregiver issues with someone with dementia, all in a half day, all those different things. Then in the afternoon, you could treat a kiddo with ADHD, then you could see someone with uncontrolled type 2 diabetes, someone who's suicidal, and then someone who's transitioning from high school to college and needs some coping skills. That can all happen in one day. There's days where I'll have consults with a 2-month-old and a parent, and then a 96-year-old in the same day, which is a lot of fun, I think. You might not think that's fun, but you will. You will soon. So just some numbers for you, just to orient you as to why you are needed in primary care. Look at the first number. 84%. No identifiable organic etiology. That means all the studies that they go in order, they're going to come back negative. They're going to order, go to the lab. We're going to, go get a cardiac workup done because you feel you're having a heart attack. They're probably panic symptoms, but that's fine. Go get the lab work done. Go get that done. But 84% of the time. I'm not saying it doesn't happen where someone really just has hypothyroidism. They're not depressed. That does happen, but not a lot. Not a lot of the time. And then look at this number down here. 48%. This is actually underreported. It's a little bit higher now. It's about 52 or 53% of medications, psychiatric medications, are prescribed by non-psychiatric providers. So family docs, pediatricians, internal medicine folks, they're the ones writing these, not psychiatrists, not psych NPs. What do you think the percentages of prescriptions actually written by psychiatric providers? If about 50-ish% are written by non-psychiatric providers. 20? That's spot on. It's about 20 to 25% are actually prescribed by psychiatric providers. That's not a whole lot if you think about it. Other folks, we have subspecialists, gastroenterologists, they're writing scripts for this. They've had zero training in psychiatric meds, yet this is what's happening. So again, another reason why hopefully you'll see a trend of what I'm trying to do here for you. Are you seeing the light? Hopefully you're seeing the light here. Why do you think, so honestly, why do you think this is? Why do you think that patients rather go to primary care than come to your clinic to be treated? That's what the data nationwide shows.
I would imagine some of that's socialized, and then the stigma of like mental health that comes with it. And so, if I take a pill, and our society, right? We're a fast-paced society. Let's just take a pill and get over it and move on.
Yeah.
So I can get that from my doctor, where I
Okay, so stigma.
Also the fact that lots of times mental health comes along with physical symptoms. And
Sure.
so if you think something is physically wrong with you, why am I feeling this way? Why am I having palpitations? Why does it seem like I can't digest properly?
Exactly.
And it's because of anxiety or because you're having panic attacks, but because people don't understand
Sure.
that's what happens, they'll come to primary care because they think they need primary care.
Getting primary care. Okay, so not understanding symptoms, stigma.
It's convenient. It's more, it's kind of like an access, it's just easier.
It's
I
easy.
have my doctor,
Yeah.
I have Kresge medicine.
Yeah. For our clinic, we have same-day appointments. So if somebody doesn't feel good, and we have this happen, they'll do a same-day appointment for depression. People, they do that all the time. Versus going to other places that maybe don't have same-day appointments. Yes, ma'am.
I think it's also like a lack of, kind of like what Paul was saying, is a lack of understanding what counseling and mental health is.
Sure,
And there's
sure.
definitely stigma on it, but I think a lot of people just don't understand what it can do for you, and that's
Absolutely.
that. We do need to be more advocating about it, because it's just as needed as
Absolutely.
your regular dentist or doctor or whatever.
Absolutely.
But it's not out there the same way.
So lack of understanding, stigma, access. I'll promise I'll come to you.
I also feel like it's because they already have that relationship with their primary care provider, so
Mhm.
it's just simpler to go to them and not wanting to meet somebody new or having to form this new relationship from scratch with somebody else.
Absolutely. So the relationship with their PCP.
And just along with the access piece, like the affordability,
Yeah, absolutely.
expensive to see a psychiatrist.
It's expensive. It is.
Medical insurance
And
doesn't
medical
always cover
insurance,
Sure.
the counseling aspect, but it'll cover the medical aspect or.
Sure.
I feel like it kind of is wrong stigma, like if people, can say I have something somatically wrong with me, but it's physically wrong with me, that's not demeaning, that's not, I'm weak. But if you have something mentally wrong with you, it's wrong.
Sure.
You know what I mean? It's like, I'd rather just not know.
Got it.
You know what
Okay.
I mean? So I feel like it's so much easier to accept going to the doctor rather than going to a psychiatrist or going to a counselor.
Sure. Absolutely. Any other things? These are great. What about transportation? That's the number one thing that always pops up on surveys. Patients say, I can't get there, or I don't have the bus fare to get there. So if you think about what it takes to make a psychotherapy appointment, we'll focus on that for a patient. Intakes are, I haven't done an intake since grad school because I've always been in primary care. How long are those now? Are they still 90 minutes? They can be? Are they 60 to 90 minutes now? Yes? Okay. So we'll say 90.
It depends on the client, how much they're gonna tell you.
Okay. We'll say 90. We'll say 90. Say this person's going to tell you a lot. So let's say let's just use she as an example. She has kiddos. She has to set up babysitter for kiddos if she doesn't have anyone that could help for free. If she's working, she has to take off work for that too. So there's a lot of steps to get to your appointment versus primary care. Visits are shorter, super short in some reasons. So that's not a great thing that they're really short, but they are. And maybe it's on the way to work. And maybe it's more convenient. Somebody mentioned convenient. Accessibility. She doesn't have to ask off in advance. She could literally, if she knows she's going to be off this one day of the week, I'll just make a quick same-day appointment, see my PCP, and be done with that. So we have a lot of patients when we just did a survey of our patient population about behavioral health services and primary care and their likelihood to go to specialty mental health if it wasn't present in primary care. About 85, 86-ish% of the patients said they would not go to an outside person. When we asked them qualitative feedback on, well, why not? A lot of people said transportation, that you're close to where I live. My PCP is close to where I live. The second one was they said, I like that you all take care of all of me, is what they said. That we're not having you go here for this and then here for this. And so that was pretty impactful, we thought, especially when we want to make sure that we keep behavioral health in primary care? We need some reasons, and so to hear from the patients, I think, is the best thing. But everything that you all said, too, is definitely linked to why people go here. Not saying that they won't come see you. They will come see you. Sometimes what happens, too, is that if they trust their PCP and he or she makes a recommendation that, you know what, I think you would really benefit from going to psychotherapy at this clinic. Just from that relationship patients have, folks who have a good relationship with their PCP are more likely to follow through with any referral, not just for behavioral health, but for cardiology. They're more likely to go. And so you being in primary care, you can help with that, especially if you're seeing a patient that you feel, we really need to get them into psychiatry, or you need specialty treatment for trauma that we really need to help you get to. If they trust you, they're more likely to go. So you can help with that too, believe it or not. How the PCP relates to their patient, you all can help them do a better job with that. Because they'll ask you. They will ask you. They will ask you. For sure. Okay. Spending too much time on this slide. Okay. So why do this? This comes to no surprise, as I just said. People come to primary care with behavioral health issues. And not just depression, anxiety, as I said, coping with chronic conditions is another big piece. Behavioral health problems are expensive, and they're disabling. And guess what? If you treat it, costs go down. Who would have thought? That if you treat it, costs go down. Does anybody know what it costs for one day in a hospital inpatient stay? Whether it's psychiatric or medical bed? Yeah, $8,000 to $10,000 a day for patients. We could fund behavioral health folks in tons of clinic with some money from that to show them that you guys can help decrease this by you addressing these things in primary care before it gets to the point where they're hospitalized because they're so depressed. They haven't taken their metformin for their diabetes for months because they can barely get out of bed. If they had you there, you guys could help with this. Okay, I gotta get closer. Okay, so what does this look like? There we go. So these are the things that you all will be doing very, very soon. So the focus, of course, is on brief intervention. So doing visits that are anywhere from 15 to 30 minutes at a time in primary care. So people often think of the one-on-one visits, which are great, and screening, but they forget that you all can help with classes and workshops and group visits, whether it's for depression classes, insomnia classes, parenting classes, chronic pain classes, groups for people who are going through pregnancy. There's so many things that you all can help with. Below are some ratios there, just to give you an idea. In a practice that's up and running, for every 4 full-time primary care providers, it's about 1 full-time BHC. Again, the more complex and medically sick your population is, you may need 2 behavioral health consultants for every 4. Pediatrics is 3 to 1, so is geriatrics. For those of you who are maybe thinking about after this, maybe I just want to see all older adults. Maybe not. Or pediatric practices are desperate for behavioral health. And so if you're really interested in child and adolescent, there's lots of pediatric practices that are hiring behavioral health folks too. Homeless clinics are usually reverse. It's for every 1 PCP, 2 full-time BHCs. And then for clinics that have a psychiatrist that serves as a consultant, you can get by with a lot. They're typically not there to see patients one-on-one. They're there to consult for the PCPs. Say they have a question on, I don't know what medication I should start for this patient with bipolar 1. What recommendations would you make? They could call the consulting psychiatrist to get help with that. So that's what their main role is in primary care.